Good morning and welcome to the 30th meeting of the Health and Sport Committee in 2020. We have received apologies this morning from Alex Cole-Hamilton, and I welcome Willie Rennie as a substitute for this meeting. I would ask all members please to ensure that mobile phones are on silent and all other notifications are turned off during the meeting. The first item on our agenda today is a round-table session as part of our ongoing inquiry into social care. Today we will be hearing from individuals who are receiving care or who have caring responsibilities. It is, of course, hugely important for the committee to hear first-hand from those with lived experience of social care. We're very grateful to those who have given up their time to join the committee this morning. I also thank our outreach team for identifying and supporting today's witnesses. Last week we published the results of our survey on the impact of COVID-19 on care at home, and I'm sure that some of the issues raised in that report will be relevant to our discussion today. So I'm pleased to welcome to the committee Jim Aitken, Julie Cousin, Susan Dumbleton, Ron Goldie, Steve Sinclair and Dr. Anne Wilson. Thank you all for joining us today, and thank you for the information you've provided to the committee in advance of today's meeting. I'd like to start by inviting each of you in turn to introduce yourself to the committee and tell us briefly why you are here today to speak about social care. Can I call Jim Aitken to be followed by Julie Cousin? Jim.
Yeah, my name is Jim Aitken. I'm retired now. Myself and my family, we've experienced care through all of its guises, some good and not so good, over the last few years. We've been, myself, my brother, my wife and my sister-in-law have been caregivers. Our parents have been the recipients of care too from care workers, and latterly my mum is now in a dementia care home. So we've experienced the whole gamut of care. And I think I've got some quite valuable contributions to make to the conversation about how we might improve some of that.
Excellent, thank you very much. And can I call Julie Cousin to be followed by Susan Dumbleton? Julie.
Good morning. I'm carer to my son, who is 24 and has autism and learning difficulties. Also, my mum, who has various medical conditions, and during COVID and lockdown, I looked after my dad, who had a 4-year battle with lung cancer. So I've had various things going on, and also was caregiver and supporting my sister, who we lost the previous year to a blood cancer. Sorry. I also am involved with disability sport. So I think there's quite a lot can be there. And during looking after my dad, was involved with the people who come in, carers who come in to help look after my dad. So it was a joint working. So I've seen a lot of different aspects of working together and what can work well.
Thank you very much. Susan Dumbleton to be followed by Ron Goldie. Susan.
Good morning, I'm Sue Dumbleton. I am also a family carer, also for somebody who has a learning disability. My daughter, who is now in her 30s, so been involved obviously all her life trying to organise services that are appropriate to her, and that's something that I anticipate continuing as long as I'm able. And I was the main family carer, not the only family carer, but the main family carer for my late mother, who died a couple of years ago, and who at the end of her life needed significant health and social care. Thank you.
Thank you very much. Ron Goldie to be followed by Steve Sinclair. Ron.
Yeah, good morning. Good morning to you. My name is Ron Goldie. Although I'm here in Warsaw in Poland at the moment, in Haddington in East, I am very much involved in due to a experience which happened a few years ago. And since then, I have been very much involved, and I have to try and try and get some changes made. Basically, that's all I can say at the moment. Yeah.
Thank you very much, Ron. And we'll see if we can get some improvement to the quality of your sound. But don't you worry about that. We'll deal with that at this end. And can I call Steve Sinclair to be followed by Dr. Anne Wilson? Steve.
Good morning. My name is Steve Sinclair. I'm disabled at birth by the drug thalidomide. I've had care all my days, my parents, and for the past 20 years I've had social care in all gamuts. I currently use a self-directed support package. And like one of the previous speakers, there's good and bad, and let's hope we can get a system put in place for the benefit of all.
Thank you very much. And finally, Dr. Anne Wilson.
Yes, my name is Dr. Anne Wilson. I'm a retired general practitioner, and I'm in receipt of direct payments, and I receive support. Also, within my household is my grandson, who is also in receipt of care because of the mental health issues. So I have experience of care support being given both to my grandson and to myself. Also, I've been involved in the disability rights movement for many, many years, since I retired in the late 90s. So I've had experience of the difficulties that support workers have in providing decent support over the years. I think that's all I have to say at the moment.
That's excellent. Thank you very much. And that gives us a good indication of everybody's expertise and backgrounds and what you know about from your own experience. And I guess we'll now move on to questions and discussion. I'll encourage members of the committee to enter an R in the chat box to ask questions as and when the questions occur to you. Don't wait for someone else to go first. We want to have as full a discussion as we can over the next hour or so. Can I start by asking, perhaps with yourself, Anne, you mentioned disability rights being something you'd taken a great interest in. I guess my question is, what more can be done, or is there more needing to be done to involve the receivers of care in decisions made about care? And if so, where should we start with doing that? And can I say to other witnesses, if a question sounds, if you fancy answering a question, just please enter R in the chat box, and I'll come to you as soon as I can. Anne, would you like to start off on that one?
Yes, I think that those people providing support and people who are in receipt of support, they should both be involved at the very beginning of any policy changes or policy discussions on how we should deliver that. I'm really keen that to see those people who are at the moment called care workers should be given a more professional status. And I would really like them to be called support workers rather than carers. I think people who care are the people who have an emotional link to the recipient, a daughter or a mother, or they are caregivers, whereas people who are paid to support a person should be called something different. And I like to use the word support workers. And I know that there is work going ahead to establish a national organisation, which I think would be a very good thing, so that we can have a professional pathway for people providing support. But I would like to see that it's not called a national care service, but perhaps a national care and support service, or even national support service, so that immediately you begin to professionalise these wonderful people who give tremendous support to people who require the support to take part in normal everyday activities.
Thank you very much. Julie, and then I'll call Julie and then Sue, but Julie first.
To follow up with what Anne was saying, I agree with that. And my point would be that carers, as we are known, unpaid carers, could be recognised as a professional and skilled part of society, and it could be looked at and given a qualification, and that be training given and monitored, so that we are recognised along with our colleagues out there who are giving care, because we are part of a workforce, albeit unpaid. And I think that came across during lockdown, that we stepped and we were there, and without our skills, many of our young people and the people that we care for, young, old, some very, very poorly, would have had no one to look after them. And I think our skills are professional. Our skills should be recognised in a professional way, and that should be a professional qualification that and the compliance attached with that.
Okay, that's certainly an interesting proposition. Sue.
I was going to just respond to what Anne had said about the workforce being professionalised. I mean, in a sense it is, in that social services workers are regulated and have to achieve a certain level of qualification in order to practice. Now, how well that works is maybe for debate, but there does exist a professionalisation of the workforce. But if I may, I would just like to respond to Julie as well and say I thought that was a really interesting idea that she had. I think that would be very difficult put into practice, just because of, well, I suppose human rights issues, that perhaps not all family carers would wish to be seen as professionalisable, if that's a word. But I think it's definitely something worth talking about, and I don't think anybody would disagree that the skills that family carers have are, well, vital really to how the whole care and support situation works for people. Okay.
Thank you. Thank you very much. I guess I would perhaps want to go back to Julie and ask, put that point to her in a way that while I think we all recognise the huge expertise and contribution of family carers, in a sense, part of the reason it works is because it's not, it doesn't require a formal qualification. Julie, would you want to comment on that?
Yeah, I would say that I think that there should be an option there. I think that perhaps there are a lot of carers who do feel undervalued in their role, yes. Because they hear, and I think it was very relevant during COVID, where we didn't have the option to go into shops where NHS workers, and it got to the point where so people who were coming in and looking after my dad with me could access shopping at a quieter time. I had to stand in a long queue, and I was looking after 3 people: my son, my mum and my dad, and I didn't have that option. So I was undervalued, and there were many others. There were carers who were looking after lots of young children, several as part of Deaf and Abled Scotland, and being on the board, I know, so as a network, there were lots of families and they were in the same situation, so very undervalued. I feel so. So I think, people should have that choice. And I think, so I think that's my opinion.
Yes, as a choice rather than a requirement in a sense is what you're saying.
Because I think if it's a professional qualification, there should be compliance attached. It shouldn't. You want to be seen as a skilled professional, so there should be compliance attached with that. And if you choose to go for that, then that's your choice to do that.
Okay, thank you very much, Steve.
Yep, I'm very interested in listening to the lady speaking there. As somebody that's cared for, both by family and by paid carers, I'm not so sure that my family members would want to get a professional qualification, because after all, I help care for my aged parents, and that's not a chore, it's a choice. And I feel if you made it legislated that you had to go for a professional, that it has to be by choice whether you want to pursue that. I don't think that it's something that can be put on. As for the shopping, I just gave my carers a letter because they work for me privately, and a lot of local supermarkets let them, they got known, they were allowed in because they were caring. It was a question of communication. It worked for me. I'm aware of others that it didn't work for. The whole COVID thing caused absolute mayhem as somebody being cared for. Indeed, for the first 4 weeks of the pandemic, I moved my main carer into my home with me and my wife. I was lucky I could do that, but I know of others who couldn't and struggled very, very badly. I think it's very interesting from my perspective listening to people who are providing the care and their input from the opposite perspective of myself. And I just think that self-directed support for me has been a boon. It's given me back my freedom in my life. Whereas in other aspects of care, when the local authority was organising it, it was very much, you'll have your breakfast at 8, your lunch at 12, your tea at 3, and you'll go to bed at 8. There was no flexibility in that. And at that time, I was in my mid-40s. I didn't want to go to my bed at 8 o'clock at night. I didn't want my tea at 3 o'clock in the afternoon. So there's a whole gamut of things. Professional qualifications, I give my carers the option if they want, they have qualifications, but if they want to go and do the same level as local authority carers are having to do just now, and I'm sorry, it's gone out of my head, there's maybe somebody else can come in and remind me what it is, but there is a qualification, is it HND, HNC level that the carers do go for. And if that's something that interests people, I'm sure there could be provision made for it. I hope I've made sense there. I lost train of thought. Sorry.
No, it makes total sense. Thank you very much. I wonder, Jim, you've seen it from both sides as both a receiver and a giver of care. I wonder if you have a view on these.
I think it's a really interesting. I really think it's an interesting idea. I suppose the only thing that would concern me a little bit about it would be you would have to create a whole bureaucracy around it to enable it to function. And one of the things that I think that kind of people struggle with is that the care system, the support system, I quite like that name actually, support rather than care system. The support system is complicated enough as it is, doesn't seem terribly joined up. So I'd just be concerned about another level of bureaucracy that might introduce.
Sure. No, I think that's right. But I think it's been very interesting just to have the discussion and see that there are different views among people at the front line, so to speak. Emma Harper, I think, wanted to come in with a question on self-directed support, which we just heard from Stephen Sinclair about. Emma.
Thank you, Convener. Good morning to everybody. I am interested in issues around self-directed support. In our briefing papers, there's been a couple of comments, and one of them is that local authorities are unwilling to be flexible on spending of budgets. And it says here, they made my life a misery when I asked to use £300 to buy a piece of equipment. And it seems like there is different options of self-directed support. But one of the issues was that local authorities don't like SDS and put barriers in the way. So I'd be interested to hear in what your perception is of self-directed support and whether it works well, whether there is issues, and any feedback that you can tell me about self-directed support would be appreciated.
Thank you very much. Maybe start with Sue.
Thank you. This is a very personal experience in that my daughter, who does get support from the local authority, to the best of my knowledge, self-directed support has never been discussed with her, never. That's not to say it wouldn't be a possibility, but it has never proactively come her way. However, she does have a very small direct payment, which really her family carers have organised this on her behalf. And when the idea was put by us to the local authority, there was no objection to it. In fact, they were very flexible about the use of the direct payment, and it was quite a creative idea, and she traded in a couple of her support hours for this very small direct payment, and that there was absolutely no trouble with it. The idea had to come from us, but that's okay because ideas have to come from somewhere. The barrier is the accounting for this tiny sum of money. And that's because it's an administrative task, and we understand it's public money, it has to be accounted for. But the way it's done is, it's a bureaucratic process, it's not a human process. And I really don't think someone with a learning disability would be able to understand the questions that are being asked and the way that the accounting is done. So I think there's barriers other than the ideas around self-directed support that really, from my experience, really do need to be looked at.
Thank you. Steve.
To answer Emma there, I was on local authority support and wanted to transfer to self-directed support, and it was like turkeys voting for Christmas, because it wasn't so much with the carers, but the people in the office. If I moved, it was a client less budget. That was 15 years ago, to be fair. Since then, moving areas, it's been a lot easier. Self-directed support, as I said earlier, has given me my life back. The carers that worked, at that time it was North Lanarkshire, the carers that worked for them went above and beyond, but their hands were tied with what they were allowed to do, the jobs that they were given, the times they were given to do it in. It was a heavily subscribed service. Self-directed support's given me the freedom to live my life again. Since I got self-directed support, I got married, incidentally, not to one of my carers, but somebody I met. But I've lived in 3 different local authority areas since being awarded self-directed support, and every one has a different way of running it. The lady before mentioned the bureaucracy and how to fill in the forms, and we have to account for the money because it is public money. We're well aware of that. But I also am in receipt of the Independent Living Fund, which is a godsend, and I'm grateful that Scotland kept it after England abolished it. But my question would be, why can't local authorities adopt an agreed system Scotland-wide to manage self-directed support in a more simplified manner, where we still account for how we spend the money on carers? And it's fairly simple, because if you've got a paid carer, you have somebody somewhere doing the wage slips and what you're paying, etc. There's various bodies do it. There's also, I prefer to employ an accountant. So you have the records of where you've spent. You have a bank account the money goes into, so you can see what's coming out. It would be easy just to provide bank statements every 3 months and a copy of the wage slips. But why can't Scotland as a country provide a one-size-fits-all service that each local authority has to either abide by or put in a system similar to that used by the Independent Living Fund, that there's a central body deals with the payments for self-directed support and make it easier for people to manage the budget. Because in one area, it was very straightforward. When I moved to the Borders, it was a different system. It took a bit of getting used to. I've now moved to North Ayrshire, and at times you feel as though you need to be a Mensa candidate just to deal with justifying where the money goes. And I keep saying, I've got money in it. I've got more than I've got more than I should have. I need a new wheelchair, or I need this, and it's like trying to crack open a walnut with a toothpick. It's not that easy. But if I get it's public money, but can we not just have the one system and one body overseeing it so that you know what's expected from you? Sorry, I've waffled, but it's so you know what is expected from you, and that public money is protected.
That's again very interesting point, very worthwhile. Can I call Julie, and then I'll maybe come to Ron after that. Julie.
Yes, so I've got a couple of examples, and it's from different local authorities. One regarding my son, who received self-directed support, and we approached the local social work department because he wanted to make a slight change, and we had asked for the senior social worker to phone back to discuss what he wanted to change and what he wanted to do. And without even having a discussion, we spoke to the duty worker. They went off and called back, and it was a point blank no. And he can't understand why there's not a proper consultation and conversation taking place where his views are listened to, because that's the way it should be. He should be heard, and there should be a proper conversation around it where it feels to him, and I would agree, that he is dismissed. Communication is key, and for Ryan, who's autistic, it's all about, he always says it's about transparency, information and communication, and if that all works together, even if the outcome is still that they don't change anything, he knows that his voice is being heard. As a young person with a disability, he's being heard, and that's fine. The other instance is a young man who, it turns out, I'm working with him. I work as a personal trainer, and I'm working outdoors with him. And he was, it turns out, now 3 years ago, he was given self-directed support. He's only just discovered this. He left school and went to a garden centre. His mum was under the understanding that the social worker had just found this place for him because he has learning disabilities and college wasn't going to be an option. And I was saying to her, I think there's self-directed support going on in the background here, because all of a sudden he was asked to pay a rather large amount of money, from going from £10 a week, this went up to £160 a month. He had gone to Citizens Advice. They were saying that this, he can't afford to pay this, but he was having to pay it. And we've now recently discovered, because I asked her to get in touch, the social worker had left, and we now have got a contact. He has self-directed support. She's never seen a contract, even though at the time when he was leaving, she was applying for guardianship, and only just this week she now has seen this. Turns out he has this option. All the support stopped when lockdown happened, and she's now asking if that can be switched to a different option. But this young man was going through the whole in transition without his mum knowing, even though he was in an ASN school and he has a learning disability. None of the two of them, he obviously didn't understand, and his parent had no knowledge of self-directed support assessment taking place. And the other instance is a young lady who was given self-directed support to move into her own flat. She needed help with cooking, planning. COVID struck, and literally everything was taken away overnight, and she was left with no support at all. Her parents had to step in, and she was 2 months down the line, no support. She couldn't operate Zoom. She had no communication whatsoever. And if you were paying and you're paying money towards this self-directed support package. So surely it's not just the responsibility of the family to step in there. The service who are providing that support, surely they should have plans in place for emergencies to ensure that that young person is not left isolated with no support, especially when it comes to food, shopping, making meals, communication with the outside world. There has to be a joined up working to make sure that these cases don't happen. How do we, we have to plan for that going forward?
Yeah, absolutely. Thanks very much. Some very good examples there. Can I ask Ron if there are examples in your experience as well? And then after Ron, we'll come to Anne. Ron.
Okay, thank you very much. I'm going to go back a few years now to when I lived in Germany for 25 years, and unfortunately I lost my wife over there in April 2010. I made the spontaneous decision to come back home again after, as I said, 25 years. And when I came home, I was obviously distraught. I just lost my wife, and etc., etc. I was in a bad way, and I was driving around the country. I was staying with my family, which was uncomfortable to say the least, and I really didn't know where I should go to get help. And I sat in my car one evening and sat there, either throw myself off the nearest bridge or I go to get help. So I decided on the latter to go to get help, and I drove myself to the Royal Edinburgh Hospital, where I was told, no, this is not the place for you, I'm sorry, and they turned me away. And I said, well, where am I supposed to go then? Try the Samaritans, they told me. And I refused to go. I said, look, I need help here. I said, someone should be available to help me. I said, but yeah. Well, anyway, eventually a couple of people came in. I assumed they were psychiatric nurses or something. They had a chat with me, and they said to me, well, I'll tell you what, you go home, and we will come in the morning and we'll have a chat with you. That never happened. And I was left to my own devices. Eventually, I moved house. I managed to get an apartment of my own, and I moved. And my doctor found me in a state. Somehow or other, I managed to get in the door. My doctor found me, I had overdosed and things like that. I was in a bad way. And it was only then was I offered any counselling or anything like that. Since then, I have made it a sort of a campaign, as you might say, for the rights of people with mental health issues. Now, I work closely with CAPS Advocacy and various other organisations. And with CAPS Advocacy, we'll have to sort of formulate a report regarding all this. And I was invited to join the Patients' Council at the Royal Edinburgh Hospital. I went there and we had a chat with the people from Royal Edinburgh Hospital, and the stories they were telling me were horrendous. And I thought to myself, this shouldn't be going on in this day and age. So I came home with, after handing over what I could to CAPS Advocacy, and I got a phone call a couple of days later from the chairman of the Patients' Council at Royal Edinburgh Hospital. We don't want you to come back, he said. And I said, why is this? You asked too many questions. And I said, you are kidding me. And he said, no, they said, I've been told you asked too many questions. I said, no, you're wrong. I said, the patients they volunteered the information to me. I said, I didn't have to ask anything. Now, since then, I have made it my business to look into those things, and in a peer support role, you might say, I've been looking at things, various aspects, and I've been chatting to people who have been admitted or not admitted to the Royal Edinburgh Hospital, and these things are still going on, apparently. Why? Why are they still going on? I feel that the Parliament should be looking into those allegations, at least looking into the allegations, not just brushing them under the carpet as though they didn't happen. They say there's a lot of financial help going into the mental health system. Where is it going? No one knows. The other thing is I spoke to a night nurse who worked in the Royal Edinburgh Hospital, and I was told that they actually sedate the patients so that they can have a quiet night. should this be going on in this day and age regarding mental health people? Now, Scotland has the highest rate of suicides, mental, or should I say male suicides in Western Europe. Why is this? Because they cannot get the treatment they ask for.
I think that's a really important point, and certainly something we will come back to. Can I move to Anne Wilson next, and the subject of self-directed support, and I know you wanted to say something on that topic too, Anne.
Yes, I've been listening to all the other people who are giving examples to you, and I'm really aware that the deliverers of the direct payment of the self-directed support, the social work department, it varies considerably from one local authority to the next as to how they handle it. I was involved in Dumfries and Galloway. I was involved in training of social workers when the change to self-directed support came about with the Act. And I was well aware that a lot of the social workers didn't get it. They really didn't understand the concept of it being a person-centred service, and that they would be trying their best to continue to manage the client. And I think I don't know how we can deal with that, but we've got to somehow level the playing field so that the delivery of self-directed support across Scotland is fair and equitable, and that maybe it shouldn't be the social work department that deals with this. Maybe it should be, if we have a national care and support service, maybe it be maybe that service should actually deal with the self-directed support. It's true. The other thing is that the social work department is under terrific strain, certainly in this area. They're with the financial cutbacks. I think there's less and less social workers on the ground, so to speak, and it's just impossible to get hold of a social worker. We called for some help from the mental health department, and they're much better, in fact, for my grandson. But trying to get hold of a social worker, you can wait forever to actually even to speak to a social worker, and this shouldn't go on.
Sure.
You should be able to get a response from your social worker. I don't even know who mine is. And they keep changing and so on and so forth. And I think it's because they're just, because of the cutbacks, there aren't enough being employed.
Okay.
And it comes down to money. It comes down to the finance.
Yes, often true. Yep.
Yeah, and also when we're discussing support workers themselves, they are not adequately remunerated. They need a huge hike in salary.
Yes, I think there'll be we've certainly heard other evidence to that effect. Can I ask? We've got a number of people who want to contribute. Can I come back to Emma first of all, and then I've got Jim and Julie and Sue. Emma.
It's interesting to hear that the different local authorities do self-directed support or manage it in different ways. So that's something obviously we can explore. And it's also interesting to hear Dr. Wilson's comments about access to social workers. So I'm curious whether it's got worse, obviously, during COVID, or whether it got worse even before the pandemic. And I see that Sue is interested in that.
Sue was keen to respond to that. But before I come to Sue, I'll take Jim and then Sue. Jim.
Yeah, thanks, Lewis. I mean, I think that the point actually touches on a sort of wider issue with social care more generally, and the fact is that it does seem to be something of a postcode lottery. The level of care and support you get varies quite significantly from one local authority to another, and I think there's a bit of a win to be had here if we can somehow bring together all of these resources into one place so that they're properly managed and controlled. So that if you live in Shetland or you live in Edinburgh, you know you're going to get the same level of support.
Yeah, absolutely. Sue. Sorry, Sue, we're not hearing it. Yep, carry on. Start again.
Okay, my response was really to Emma's question about is it worse during COVID pandemic, and I mean the answer to that has got to be yes, and everything is worse during COVID and during lockdowns, and I think this may be what I wanted to say maybe relates to what Jim has just said, that this is something that is a lot wider than care and support. This is about our social organisations and the way we approach support to people who need a wee bit of extra help. And I think it's maybe not right to just put it all onto social work departments or social workers or mental health nurses. I mean, this is far wider, I think, than that. And to illustrate that, and I think we can use the pandemic, that the informal structures, which have so often been the things that have supported people's lives, not the formal paid for care and support, vitally important though that is, but it's the things that go on in society which also help people to live a full and fulfilled life. And so many of them have gone. They've just gone and they may never come back again. And I think there's a huge issue there for not just for the formal structures, how social capital in Scotland is strengthened and increased. So we try to support those informal structures, not just families, again, vitally important though they are. And goodness me, we all know how important family support is and how things just wouldn't operate if it wasn't there. Similarly for paid formal structures, but it's the other things, the opportunities, the wee bits of voluntary work, that whatever it is that people's social networks consist of, and so many of them have gone. And I don't know whether there's been any research done into that. I really think it's important. Thank you.
Thank you very much. I think Julie wanted to come in a little while ago, and then I'll come to Dave Stewart, MSP. Julie.
You know, I think we're looking at the future, and I think it's not about reinventing. It's about looking at the good practice that's there and building upon that. And I think Steve mentioned ILF, and you know, it's person-centred, patient-centred, and I think, you know, I had good experience with my dad. My dad came out of hospital, and I think that there was great examples there. You know, it was built around what were his needs, and I had picked up the phone as things changed. He went from palliative to end of life, and I was able to pick up the phone, and I got a social worker in the end of the phone, and it literally could be from one day to the next to the following week saying this has changed, and things were put in place very quickly. And it should be streamlined across all local authorities up and down the country. It should not be a postcode lottery, and that's what we need to work on. Good practice across the country and having that streamlined, that if it can be a success in one area, it can be a success across the country, and that's what we need to build upon. If it works for ILF Scotland and the Independent Living Fund, and also I see it with the Transitions Fund for young people, because they ask them what will work for you, and it evolves because they listen to feedback from the young people, they listen to feedback from parent carers, and it evolves in that way, and they adapt and they change, and I think that's the future going forward. Everybody working together, jointly, collaboratively, and I think that's the future of social care going forward, us all working together.
Thank you very much. I have a number of MSP colleagues who have questions. Sandra White has just reminded me she had a question early on about, I think, about PPE, if I'm right, Sandra. Sandra White.
Thank you very much, convener. I don't know what happened to my computer. I'm working on the small tablet at the moment. I noticed when I was looking through the information from the witnesses, and thank you so much for what you have said already. It's been very interesting. 3 out of the 6 particularly mentioned difficulties with obtaining PPE, and I just wondered if they could elaborate on why they had difficulties and how they actually managed to get PPE from everyone, or just the 3 that actually mentioned it in their contribution there.
Steve, I think you mentioned, I think that was one, and then I have Anne. Steve.
Oh, sorry, I was just going to type R in and the screen disappeared. PPE was a problem. Initially, everybody and their dog was buying PPE, and it made it very difficult for those that needed it. The local authority eventually stepped in and gave us access to their stock, so to speak, where they handed it out to their own home care team. But they only did that once, probably because the other streams opened up. But the issue I had was that the PPE can be paid for from your self-directed support budget. Quite rightly, you need a receipt, but it gets questioned every time. I mean, I buy my PPE in bulk, so it's probably, £40 a month or whatever for all the different bits and pieces that are needed. And every time they go through, what's that for? Where's the receipt? And it's the same, it's give or take the same amount, but accessing it was difficult because everybody was getting it. That seems now to have, it's been worked through and it's now more freely available. But it was, I don't want to go into it, but some of the, I mean, obviously I'm getting showered by carers. They need PPE. You can't reuse it. That was difficult. But it's resolved itself now, but initially it was an absolute nightmare.
Yeah, very interesting. Anne.
Obtaining PPE was a complete disaster. You just didn't know where to get it, whether you were responsible for it or whether the support worker was responsible for it, whether you had to pay for it or whether you could receive it from the social work department free. And if you paid for it, did it come out of your direct payment? And if so, was your direct payment to be increased or what? There was just no guidance whatsoever. And you'd get when you finally managed to speak to a social worker, you would get a different response each time. And the response varied from, oh, come and get some, to, oh, you have to buy it yourself. So there was no guidance whatsoever. They obviously didn't know what they were supposed to be doing about it. And we didn't know what we were supposed to be doing about it.
Sure. I think it was Julie was the other person who mentioned PPE in advance of the meeting. Julie.
Initially, yeah, we didn't have any either, and we sourced our own. My partner who was making turned the whisky industry turned into a hand sanitizer producer, and he managed to source PPE. And I think it was maybe a month down the line we were contacted and told we could have some, but by then, yeah, we had just bought our own, which allowed Ryan to continue to work with his PA, and that was otherwise, yeah, we wouldn't have been able to continue that contact, which was vital for Ryan. Yeah.
Yeah, Yeah, very interesting experiences. I have a question from David Stewart.
Thank you, Convener. And can I thank the witnesses for the really important evidence? And I wanted to touch on a couple of points that Jim and Julie made, and that's really about how we fund social care in the future. I think Jim mentioned the postcode lottery problem of different local authority areas having different approaches. And we all know the increase in demands because of the growth of people, numbers over 80, growth in dementia and diabetes. So my point to the witnesses is, how do we fund this in the long term, bearing in mind since 2013 we've seen an increase of about 7% in the NHS budget, while we've seen a cut from Professor Bell's figures of about 13% funding. Is it time we had a different model? Do we look at apothication, in other words, raising tax specifically for social care? So how do we square the circle? Demands are going up, but budgets are going down in some aspects of social care funding.
Jim, I think, would want to comment on that. Jim Aiken.
Yeah, this is something we've got direct experience of. It's a really interesting question, and there isn't an easy answer to it, but I suppose the context is important here. The cliff edge that exists, financial cliff edge that exists between care in the home and then care in a care home is just astronomical, eye-watering. I'm going to use my mum as an example. It's a kind of everyman's story, but it's very personal to us. My mum and dad, in their later life, were really quite poorly. My dad was physically very poorly and in poor mental health. My mum suffered from dementia. And initially, the care was provided primarily by my brother, because he lived quite close to them, but also by me. But as their care deteriorated, then we approached the local authority to get some help with the care in home. And they were fantastic. I've got nothing but praise for them. My dad passed away, though, and no exaggeration to say, my poor wee mum literally fell off a cliff edge mentally. And all of the care, all the professionals who were looking after her said she reached the point where she needed 100% professional care all of the time. And the only real option that we had was to put her into a care home. So when she was getting care at home, it was effectively free at the point of delivery. Once she went into a care home, overnight, the cost went from £0 to £42,000 a year. £0 to £42,000 a year. My wee mum, our combined pension is £22,000. So there's a gap of about £23,000 now between what she gets from her income and what she has to pay out. We had to sell the home to pay for that, and probably within 4 years, all of her life savings, apart from a small amount, will be wiped out. Now, we do get some support through social care. It's about £190 a month. It pays for 1 day's care. So that's the context within which this exists. As I said, it's not a story that's unique to me, but it feels very personal to us. The thing that I find particularly troubling about all of this, my mum when she was working, worked for the NHS. She was a nurse. She started off as an enrolled nurse. By the end of her career, she was the senior nursing officer in charge of the Glasgow Royal Infirmary. So all of her life, she provided care for people, and it was free at the point of delivery. At the one time in my mum's life, when she needs help, needs professional help, it's beyond my brother and I's ability to do this, and she couldn't get care at home because she's so poorly, she's having to pay all that money. And I'm deeply troubled by all that. It seems deeply unfair. I do accept that, she probably has to make a contribution towards that care, but it just feels like she's paying for everybody. Now, the question then, how do we fund for it? Well, that's the $64 squillion question, really, isn't it? And I think there are going to have to be some hard choices made by us as a society. I think the taxation component will have to come in. Do I have the answer to that? No, I don't. I wish I did. But I think there are some hard choices that are going to have to be made by society, and I think it's a conversation that we're going to have openly about those choices. So that's the kind of context within which I think this is a really key issue. And as I said, it's an everyman story as well, so it's not unique to us.
It's not unique, but it's very good to get such a personal example of something that we are aware of more broadly. Steve.
The funding side of things, as Ron's just said, it's a £64 million question. I'm sitting and I'm thinking to myself, £42,000 a year for a care home, and I'm doing the maths for a team of carers in a home. There must be a better way to fund it. It all has to be about choice. Some people may prefer a care home and the costs involved. But others may prefer to stay in their own home. My own father's 89, has vascular dementia, and he's been cared for at home with a combination of family and carers. COVID has meant it is likely that he may have needed to go into a care home this year, but because of COVID and things, we've done our best to prevent that. From my perspective, people that have worked all their days, a senior nursing officer at Glasgow Royal Infirmary has worked hard all their days, and what she's worked for her and her family, and has been taken away, whereas somebody who perhaps hasn't made that contribution to society has been looked after. It's correct to look after the citizens, but we have to have it more level. That's not somebody that's won the lottery and's got 10 million quid and is paying a higher rate of tax. That's somebody that's worked in a job and is now being taxed again to pay for their care. And, it just doesn't sit well with me. How to fund self-directed support. When I first got self-directed support, I was living in North Lanarkshire, and their budget was something like, at that point, £25 million a year to provide the service that I was part of. When I went, if everybody had gone to self-directed support, that cost would have halved. So we have to look at how the care is provided. Choice is an important thing. I feel a national body, as I mentioned at the start of the conversation, a national body would be more cost effective. And it would be interesting to compare the costs of running the Independent Living Fund and self-directed support to see what savings, and when I say savings, what streamlining savings would bring in by having one body, because it's postcode lottery, because each local authority budgets in a different way and tries to get. It's important that those of us that are vulnerable and less able are looked after by society. There's got to be a way to balance the books a little bit better in all aspects of public money, but not just this.
Thank you very much, Steve. I'll call Julie, and after Julie, it'll be Sue. Julie.
So, when it comes down to cost, so the way we've always looked at this with Ryan is, at the moment, Ryan needs some help when it comes to not being as independent as some of his peers in society. And we always have this vision that one day he may gain that independence, and that's what we strive and we work towards. Or he will gain some more independence, and we will keep striving towards that. And we have paid and we continue to pay into society and to try and support him. So we hope that what we do helps to fund the support that Ryan and others receive. But what I would say is, my dad died with dignity, respect, and that was because of the social care system that we have. My sister, unfortunately, didn't have the same quality of care. She didn't have social care because her illness was quite short, and she didn't have that support, and she did not have dignity and respect. She received that in her last days when she went to a hospice, but she did not have that in our social care system. Sadly, it let her down very badly. So I don't think we can put a cost on that. I think having dignity and respect is so important, and I think as a nation we have to work to find that money and work together to do that, because I think for people who have disabilities and additional support needs and who are our most vulnerable in society, they deserve to be treated with equality, respect and dignity. And I think that the cost of that goes way beyond, let's look at, find those pennies. Well, yeah, we should find those pennies. We should not be putting that upon them. They are our most important to protect in society, especially during a pandemic.
Thank you very much. Sue.
Yeah, I think what I said before is the case, that this goes beyond health and social care, social work, and our sort of formal structures. And I do think Jim's right. We need to have a conversation that involves everyone. We need to make choices about the way we fund things, and it's certainly about taxation. There's no way we can provide the services that we aspire to if we don't raise the taxes to do it, and that's uncomfortable, and politicians don't like that sort of discussion. I understand why, and actually nobody likes it, but that is the way in which we can raise significant money. And I think we would all agree that social care is woefully underfunded in all senses. So if that's what, as a society, we aspire to do, then we just actually need to bite the bullet and get on and do it, because we've had these conversations for a long, long time. So if you were a Martian coming to Scotland, you might conclude that people actually, this is the situation that people want and accept. That's not what you're hearing today, but we just need to get on and do it, I think.
Thank you very much. And I think Dr. Lan Wilson wanted to contribute to this point as well. Anne.
Yes, I really agree wholeheartedly with what Sue has to say, especially to do with dignity and respect, and also from the point of view of biting the bullet and get on and do it. And what we perhaps must remember, that we were talking about adequate remuneration for support workers. If they're adequately remunerated, then they will be taxed, and it's a circular thing, that you remunerate people correctly, and then they pay back into the system with their taxes. And I think we have to have this conversation about what sort of society are we in Scotland? Are we a social society that looks after everybody, or are we not? Are we an every man for himself type of society? I think we're not. I think we're a more social society, and if that means we have to consider higher taxes, so be it.
Very much. Thank you for that. And I now have a couple of colleagues who would like to have questions to put to the witnesses. Brian Whittle and then Willie Rennie. Brian Whittle.
Thank you, Convener. Can I thank all the panellists today for very insightful points that you make. We're bouncing about a little bit here, and I apologise for this bit, but Susan Dumbleton said a couple of phrases that kind of popped a few lights on in my head. One of those was around that opportunity to be part of society. And while we're talking about the need to raise funds or raise taxation, or whatever which way we want to look at that, in terms of to make sure that we treat all of our society with the dignity and respect that they deserve. It strikes me also within that, and we've had this discussion before, Convener, around the flip side of that of it was how much we pay for things. So I wonder what the panelists thought around this idea maybe of, as part of the whole remuneration programme, there is access to free public transport, for example, or access to community facilities, or making sure that there is transport and the ability for all of society to take part in community activities for that integration. I wonder what the panellists thought of that as part of the whole programme.
I wonder if we could start maybe with Stu Dumbleton, as Brian mentioned that you had commented on part of this, and anyone else who would like to contribute, please feel free, enter in the chat box. Stu.
Thank you. Sorry, Brian, your sound dropped out for me just at the vital moment when you reflected back on what I'd said, but I think it probably was about informal opportunities. I think, was that right? Yeah, thank you. Yeah, I mean, I suppose I will bring this back to a very personal experience for my daughter, who has in the past had a lot of social opportunities which have not been part of her formal support, assessed for, paid for services. They're ones that she has either had help to access or been able to access for herself. And what they are doesn't really matter because they'll be different for everyone. But the point I was making, I think, was that a lot of them have gone because of the COVID restrictions. And they were never there for an awful lot of other people. My daughter was lucky, I suppose, in the sense that her capacities and interests matched with some local opportunities. But lots of people don't have those at all, and I quite recognise that. I think the short answer is that good, decent, dignified, respectful social care depends on an awful lot more than paid for, assessed, regulated services. I think it has to, because it is about social. It's about being part of society. And I think Anne was making that point as well, that is the kind of society that we aspire to for everyone. And I think those opportunities, I think if there are chances to strengthen those social opportunities, I really think they provide so much, probably unaccountable benefits, just in terms of being part of their community. I mean, it is so important, and it is intangible until it's gone. And a lot of it is gone now, and we can see that and the effects of that. Free public transport is just absolutely brilliant. I don't know if that answers Brian's question, but it's my.
I think it's a good part of the answer, I'm sure. Can I hear from Julie and then from Anne? Julie.
Yeah, I would definitely say transport. So regarding disability sport, I know through that a lot of our members having access to transport to get to sporting training events, and also having access to venues with regards to training for sport was a problem, finances for that, and actually getting the transport to get there, paying for that was a huge problem, always has been a problem, finding the funds for that for young people with regards to training, regular training and it takes them then, and it can take them into pathways for competitions for Special Olympics and then some of them onto obviously more elite pathways. So yes, I think that's a great idea.
And Dr. Anne Wilson.
Yes, access is a huge issue in all its forms. Access. What about people who require support, but who are able, with support, would like to be employed, would like to have but they can't access the office or wherever, or it's very good that you get free bus transport, but what if you can't get on the bus? Not all buses are accessible for wheelchair users. And if they are accessible, they take only one at a time. I have been in the situation where I've not been able to travel because there is already a wheelchair user ahead of me in the queue, and they get the one and only place. This can't be right. And so access is a huge issue, I think, and access to the built environment, and then access within the built environment it's improving gradually, but it's still a long way from what it should be. Access to rail travel is improving, but it's still, again, not good. You're treated like luggage rather than a person if you're a wheelchair user.
Thank you very much. I have a question now from Willie Rennie.
Thanks very much. I'm very sympathetic to the argument around spending and taxation. I think that is at the heart of this whole discussion. But social care is at the kind of probably the interface between the role of the state and personal responsibility and personal freedom. And I'm just wondering where the panellists think that the threshold is between the state picking up responsibility for the cost of something and the responsibility being with the individual. I mean, is it the case that if somebody is in the need of care, should all the associated costs be borne by the state, or does the individual have some responsibility? I don't know if panellists have a view on that, because it's probably a bit of a tricky question, but I would appreciate any thoughts you have on this.
It's a big question. I wonder if Jim would like to kick off. Jim.
But I suppose the answer to that is that you contrast what happens with somebody who has cancer and they get hospitalised. All of those costs are covered during the hospitalisation. Whereas somebody who's suffering from dementia and goes into care, hardly any of those costs are covered. And that seems quite anomalous to me. As I said to you, in the context of my mum, I'm personalising this again, but it's the only way I can talk about it. I absolutely accept that my mum should make some kind of contribution to her long-term care. Where I really struggle with, and that's because, as the medical professionals that looked after my mum said, she needs 100% professional care all the time. So I think there has to be a point between the state doing everything and the person doing everything, and both make a contribution towards it. Now, you could argue that actually they've already made that contribution because they've paid their tax and NIC for all of their life. So that's where the contribution comes in. Later on, when you need that help, that money's supposed to be there to help with that care. It's a $64 million question, but I tend to the view that if a medical professional says somebody needs care 100% of the time, and that's professional medical care, then most of that cost should be picked up by the state. That's the position we were in.
Yes, no, understood. Sue.
Really is a huge question, and it's a good question because it makes us all think about our personal responsibilities. I think I would just come back to what I said earlier, that the contribution of the state doesn't have to just be in the formal services. I've said this about 3 times now, but if there is some way of the state strengthening the third sector and even things that are at a much less formal community level, then I think that would pay some benefits. And I think a lot of us are very happy to contribute at a community level, trying to strengthen our society. And I think if the state could make some contribution to that, as well as all the other contributions it has to make, that would really be very helpful.
Excellent. Thank you very much. I wonder if any other members have any other questions. I'm just looking for an indication if any members want to come back on questions. David Stewart, I know, flagged up early that he had a question around the use of technology, and there he is on queue. David Stewart.
Thank you, Convener. And I think Dr. Wilson touched on my general question. I think it's very important to look at technology in the future to help towards care. Can I give you an example? In Highland, we've got this concept of fit homes, which our local Highland Health Board and Alban Housing have developed. So basically, these are barrier-free housing with state-of-the-art aids and adaptations. But the main issue is that the homes have sensor control. So health professionals, if there's any movement from individuals, this followed a tragic death of an individual in our area who had been dead for over a year before he was picked up. So I think this concept is really important. But what I mean by barrier-free takes me back to my social work days. So basically it would mean that we vary building regulations so that houses are built with, for example, wheelchair use in mind in advance, which I think was Dr. Wilson's point. So basically, my question is, could we have this form of fit homes developed across Scotland? Because my own experience working many years in social work was, in my day in the 80s, it was easier sometimes getting an individual into a care home rather than getting aids and adaptations and getting house adapted, which seemed a crazy way round of doing things. I want to try and develop this as a best practice. I would be real interested in the views of the panellists on this concept.
Thank you very much. Jim, I think, wanted to comment on that. Jim Aiken.
I think that's a really interesting one. Once again, this is personal experience. I've been to America quite a few times. And one of the things that I've noticed, for example, is that light switches in American houses are universally at wheelchair level. So you don't have to reach up to switch on a light. Now, that's a really simple adaptation we could easily make. Little things like that can make a huge difference.
Yeah, absolutely. Steve?
And also, the other one is making sure that, when you design the houses, the doors are wide enough to cope with wheelchairs. It's just universal.
Yeah. So make it the rule and rather than the exception. That being the point, I think. Steve, and then Anne. Steve.
I'm having a wry smile at the aids and adaptations in house. I'm looking up a lawn mowing home, so I have the house asympathetically adapted for my use. It's a relatively new build. Things are done for me in my wheelchair, and I've just got a vision, instead of my carer that's worked for me for 15 years or one of them coming in and helping me do what I need to get in and out of bed and up and ready, and comes Singer the robot. It just tickled my sense of humour. I think as long as we've got the human aspect and human interactions, as well as whatever aid and adaptation would help to make safety a way forward. But I'm sorry for my sense of humour. I just see Singer the robot coming in and lifting me out of bed and shouting me, etc. But yeah, I think aid and adaptation should be more available.
Next week we might invite Singer to come and give evidence, but not just yet. Anne Wilson.
Yes, I think aids and adaptations. I've had quite a few adaptations done in my house in the early noughties. I had a lift put in, for instance, with the cost was shared between social work and myself, and it's been a huge advantage to me. But I agree wholeheartedly that I think we should really look at the building regulations from now, that all new builds should be built to first what they call visitability standards, with a downstairs toilet available, and the houses should be wide enough. The passageways should be wide enough for wheelchairs. there should be level access, at least to one entrance. And I've seen new builds being built without level access. And this just seems so silly. And with just a quick aside, nothing to do with with health and social care. If we're talking about new builds, shouldn't all new builds have a regulation that they should have solar panels?
It's a very good question, but perhaps not one for this
relevant to this, but if we're talking about building regulations, that's one more bit. Yes.
Absolutely fair point indeed.
Yeah.
Okay, thank you very much. And one last question from Emma Harper.
Just to pick up what Julie said earlier about training, I think moving and handling training is something that has came across my casework previously, because if you are a person providing support or care, obviously you need to be able to protect your own health and well-being and prevent from back injuries, because if a carer ends up with sore back issues, then that puts everybody in jeopardy. So I'm interested in hearing about what support or what moving and handling training or other training has been provided as well.
Thank you very much, Emma. I think Julie will come back on that, and I know Jim wanted to come back on something as well. Julie.
So at the time when my father moved to palliative and then end of life, we were in the unfortunate position that COVID came into our lives. So there was no training, and I had to call upon my niece, who had formerly worked in a care home, and we had to ask her to come in and train us because we had no training. And my mum, who's 77 and does not and has very complex medical conditions, was not fit to move my dad and handle my dad. So my niece came in and gave me a training session on how to move and handle my dad safely. And that was the training that I had. Otherwise, I would not have been able to do what I did and care for my dad through the night, because we had the carers come in, but they could only come in at certain times, and I had to be there most of the time with my dad, so I had to rely on another family member to come to the house and train me.
Yeah. Jim and then Steve. Jim Aiken.
Technological solutions here. One of the things that I did in my previous life, I worked for HMRC, and we worked with various agencies, various stakeholders to put together a thing called Once and Done for people who passed away. So you go into when you go in, previously you would have to tell the DHSS or DSS, HMRC, everybody individually that your loved one had passed away. You now go in, you just tell one person, they tell everybody. I think there's a bit of a win here in terms of pulling together all of the information and documentation around social care into one website. So you get all of the stakeholders involved so that you identify both the physical support that's available and the financial support that's available. You access it through perhaps a Scottish Government website, but you could also access that same piece of information through local government websites, so everybody sees the same thing and does the same thing. It's a fairly easy win. And having both been involved in the design of Once and Done and then fortunately having to use it, I know that that works. So I think there's something here that I think could really benefit people in pulling all of this information together and taking some of the stress and strain away about deciding who do I deal with, who can help me here. You just go to this one source, and then all of the infrastructure sits behind that to pull it all together.
Thank you. And Steve.
The training from a self-directed support from professional carers can be covered from your self-directed support budget. They can attend the same training that somebody that works for the local social work department gets for moving and handling. It is there, but it goes back to my earlier point, as if there was a one-size-fits-all body. Gentleman before, sorry, names I'm terrible with, the Jim's on the screen too. Jim, quite right, a one-size-fits-all website, one-size-fits-all overseeing body to it. I'm lucky I've had my same paid carers for quite some time. Their training's done. It gets refreshed every 2 or 3 years at no cost to myself. But it then comes down to type of disability with moving and handling. In my community, in my community, there are people that proper moving and handling things wouldn't work with because of their disabilities. So, although it needs to be, the training needs to be there for people, for folk that are providing care for people at home. There should be access to folk to help them do it in the best possible manner. But it goes back to my original point. If we had one body overseeing all budget, the whole gamut, websites, a lot, it would be an easier process.
Thank you very much. Thank you for all of the evidence we've had. Can I ask each of the witnesses one final question? And it's a hard question because it's a question to put in a single sentence. The one thing you would most like to see change in order to improve social care in Scotland? What would be the one thing that would make the biggest difference? And can we go in the reverse order of our starting order, if everyone's happy with that? And can I start with Dr. Anne Wilson? One thing you would want to see change to make things better going forward? Anne.
That's not fair. I haven't had time to think.
I can come back to you if you like. I can come back to you if you like.
No. I think the one thing I'd like to see change is I'd like to see care workers called support workers and have the respect that they deserve through a professional pathway, adequately remunerated.
Thank you very much. Thank you. Steve Sinclair, followed by Ron Goldie. Steve Sinclair.
Oh, one sentence, difficult for me. I think standards of care, standards of service, standards of budgeting. Respect, in other words.
Thank you very much. That is indeed succinct. And if you think one sentence is difficult for you, remember you're talking to politicians. We have the same problem. Can I hear from Ron Goldie, followed by Sue Dumbleton? Ron Goldie.
Okay, thank you. I would like to see more done for the care of people with mental health issues. I feel not enough is being done at the present time, and I would like this addressed.
Excellent. Thank you very much. Can I hear Sue Dumbleton, followed by Julie Cousin? Sue.
I'd like to see creativity being included in any assessment of people's support needs. I think there's an over-reliance on what we've done before, and going on with that, really like to see the whole social services profession broadened to include more creative based.
Excellent. So more creativity is the bottom line there. And can I hear from Julie Cousin, followed by Jim Aiken? Julie.
I would like to see person-centred approach up and down the country, and I would like to be taken from the examples used by ILF Scotland, both in the Independent Living Fund and the Transitions Fund, where it's proper person-centred approaches that are taken, and I think that should be rolled out up and down the country and streamlined throughout all of our local authorities.
Thank you. And the last word, Jim Aiken.
Being more joined up, but then ultimately accessibility, fairness, affordability and simplicity.
Excellent. Well, thank you all very much. I'd like to thank all the witnesses for a fantastic evidence session this morning. I'm particularly impressed with the short, sharp points at the end, which I think you all did exactly what I hoped you would. But above and beyond that, the detail of some of your earlier answers, I think, has certainly been great from our point of view and will help to inform our inquiry going forward. You will perhaps know that we have a session next week, and you may be able to follow that on the Scottish Parliament broadcasting system as well, because we will be hearing from some of those involved in the provision of care. But many thanks to all our witnesses this morning. I will now suspend the meeting for 5 minutes, so I'd ask members not to go away, but we will resume in 5 minutes' time at 11:35, and we will hear from the Cabinet Secretary. Thanks, Lynn.
she wants to do there for Christmas New Year, but it's always been, that's supposed to be the hospital system, but there, she's my professional football player.
Hello, thank you very much, colleagues, and welcome back to our meeting of the Health and Sport Committee. We're moving now to the second item on the agenda. The second item on the agenda is subordinate legislation, consideration of 3 affirmative instruments, and as in previous weeks, these are laid under the Public Health Scotland Act in relation to international travel and coronavirus. They have been made. The affirmative procedure, in other words, did not apply at the time they were made because they were made on an emergency basis, but they now are with our committee for consideration under section 1227 of that Public Health Act. We will have an evidence session with the Cabinet Secretary for Justice and officials on the instruments. The ones we are looking at today are the Health Protection Coronavirus International Travel Scotland Amendment number 20 regulations, which removes Cyprus and Lithuania from the exempt country list. The Amendment number 21 regulations, which removed Denmark, Germany and Sweden from the exempt country list. And the Health Protection Coronavirus International Travel Scotland Amendment number 22 regulations, which make a further amendment or further amendments in relation to Denmark, requiring a stricter level and longer period of isolation for those arriving from that country. In order to answer our questions on these regulations and prior to our debate upon them, I welcome to the committee Hamza Yousaf, the Cabinet Secretary for Justice, who is accompanied once again today by Anita Poppleston, the Head of Police Complaints and Scrutiny Police Division, Craig Thompson, Border Measures Review Team Leader, and Victoria Calpin, Performance Team Lead for Test and Protect Performance and Delivery. And I would invite any members who have questions for the Cabinet Secretary before we move to the debate to indicate, or indeed his officials, to indicate in the with an R in the chat box in the usual way. Can I start, Cabinet Secretary, by asking, as I do on a fairly frequent basis, I guess, for an update on the level of contacts made by those who are required to isolate under these and previous regulations. Cabinet Secretary.
Good morning, Convener, to you and to all the other committee members. I hope you're all keeping well and keeping safe. Again, the latest figures will be the ones that were published last Wednesday. So on the week ending the 8th of November, we had 12,031 people who arrived into Scotland that required quarantining, and the number of people contacted by the National Centre was 2,964. So I'm pleased we're well exceeding that 2,000 target that we committed to do. So that was the number of contacts made. Again, fuller breakdowns available from that report, which came out last Wednesday. And of course, tomorrow's figures will give the most up-to-date in terms of the week that's just passed.
Indeed, thank you very much. And I have a question from Willie Rennie.
Cabinet Secretary, I'm interested in what's going to happen over the festive season. What intelligence do you have about travel, both in terms of students but also holiday makers? Have you got intelligence from the airlines and the travel agents as to whether there's been an increase, and whether you're going to increase capacity of the spot checking in order to make sure that we're managing to keep on top of that as well?
Cabinet Secretary.
Can I thank Willie Rennie for what's a really important question? It was something that was discussed last week's Four Nations call. The general consensus is, and of course this will be very understandable, the general consensus is that we of course won't see the same numbers travelling to catch some winter sun as we'd see in previous years over the festive break. But clearly there will be greater numbers that will travel, including, as Willie Rennie says, students. And it's why I've got a bit of concern around any piloting of a different airport testing regime. Members of this committee have asked me about looking at perhaps test and release type of scheme at an airport, and we are exploring that through the Global Travel Task Force, but there has been some robust debate around whether that should happen before the winter break or after, and my own opinion is that it probably should be after as opposed to before. In terms of additional checks, we're exceeding the 2,000 that we committed to doing. That gives us a good sample size. I'd be more than happy to enter into discussions with Public Health Scotland about whether we need to increase that capacity. My concern would be, and I'd be very frank about this, that at the moment resources will be rightly and understandably focused on the upsurge of cases we're seeing right across the country, and they are symptomatic cases, to divert resource away from those from those contacts to checking up on those people who will largely be asymptomatic international travellers. To me, wouldn't be a good use of the resource. So there isn't an intention to increase the number of contacts being made at this stage, but of course we keep that under review.
Willie Rennie, did you want to come back?
About why you wouldn't do the testing before Christmas, even on a pilot basis, and what's the logic of delaying it until afterwards, especially if you're not going to increase the numbers doing the spot check?
Well, I've not made a firm decision on it, so I wouldn't say that we definitely wouldn't do some sort of airport testing. The questions are numerous that we have to grapple with, and the clinician's view, and I just looked at the clinician's view last night, is that testing a new system that has never been tried before the winter break, when although the numbers won't be as large as they have been in previous years, they still will be greater than they currently are. Would that be a wise move, particularly because it will rely on private capacity? We don't want NHS testing capacity to be used for this type of testing. But I'm not adverse to doing it. I just have some concerns about whether or not the system that is being proposed is robust, and we're going to test that, ask the right questions that need to be asked. And if we're satisfied with the answers, then there could be an implementation of a different airport testing regime before the festive break. But it's just a really important balance we get right, that we're satisfied that we're not piloting a new system that could have some teething problems right when we're going to have a greater number of people travelling.
Thank you very much. I have a question from Emma Harper.
Thank you, Convener. Good morning, Cabinet Secretary. Just to pick up on Willie Rennie's comment about any testing, and if any new testing regime was going to be implemented, whether it was a private sector or not, it would have to be robust and evidence-based, and we wouldn't want to see any false positives or which might make people, proceed in a way that would then change their behaviour than if they had a true positive. So would that be a valuable statement to say that we need to make sure that any regime that's tested or piloted needs to be robust and secure?
Cabinet Secretary.
In short, yes. I think that's why the proposal that we'll probably see won't include an immediate test on arrival, though that again is something that's worth considering. It may well be that people get tested on day 7 or day 8, for example, and therefore the quarantine period is shortened slightly if that is safe to do so. But again, the clinicians are going through the detail of what's what the Global Travel Task Force is looking at. Again, we haven't had the paper in all of its detail yet, so we're expecting it pretty imminently. It was towards the end of this month. Well, actually, I think it's probably next week that the task force will present that paper, and we'll try to work, as we always do, on a 4 nations basis. I think it would be preferable to have a new system in place right across the 4 nations. But Emma Harper's right, we really do have to test it, particularly in advance of larger numbers, greater numbers, I should say, travelling out of the country during the festive break and returning.
Thank you, Cabinet Secretary. I think I'm satisfied with that answer. Am I right then to take what you say as meaning that if the capacity was there, then it could be done and it could shorten the quarantine period from the current 14 days to 7 or 8 days potentially. And the issue then is whether the capacity can be achieved over the next period to meet this and the other likely future demands on the testing system. Cabinet Secretary.
So you're certainly right. Capacity is absolutely one of the key issues. And again, I stress it would be private sector capacity. We don't want NHS capacity being used for people going to Lanzarote for a week for some winter sun. We want it to be used for those cases in the community that are needing tested. So private sector capacity, and that is increasing. It's scaling up to quite an extent. So we need to make sure that there's the appropriate private sector capacity. We also just need to measure the effectiveness. So quarantine, our clinicians will absolutely tell us that quarantine for 14 days is an effective measure. But there's also, rightly, as this committee has often probed, questions around how often people are actually quarantining for the full 14 days, and when they tail off towards day 10, 11, 12, 13, 14, do they become less compliant, especially if they're asymptomatic? And weighing that up against the possibility of being released early from quarantine after a negative test. So these are all questions that are being probed at the moment. As I say, we're expecting fuller detail from the UK government's Global Travel Task Force pretty imminently. And as I say, we'll try to work on a 4 nations basis on this. There is just a big question to ask over whether or not it is sensible to test any pilot like this before the festive break or during the off-peak season.
Thank you very much, Cabinet Secretary. There are no further members indicating that they wish to ask questions at this stage. We now move to agenda items 3 to 5 inclusive, which are the formal debates on the made affirmative instruments on which we have just taken evidence. Are members content that we have a single debate covering all of these instruments together? Members are content. Thank you very much. I would then remind members that we are now moving to a formal debate and that it will be for the Minister to move the motions in a moment, and there will be no questions as such, but if members wish to contribute, of course, they should do so and indicate in the usual way. Can I invite the Cabinet Secretary to speak to and move motions S5M 23216, S5M 23285 and S5M 23297. Cabinet Secretary.
Thank you, Convener. As always, I'll waive the right to speak, as we've just had some Q&A. I will just remark that I've never known more about Danish mink farms than I do now. And with that, I will move motions S5M 23216, S5M 23285 and S5M 23297, all in my name.
Thank you very much, Cabinet Secretary. Are there any members who wish to contribute to the debate on these motions? If not, we will move directly to conclusion. The Cabinet Secretary, I take it, other than the observations he has just made, has no further concluding remarks to make on this debate. Cabinet Secretary. Thank you very much.
As soon as I receive detail and confirmation of any airport testing regime, I'll ensure the committee are informed.
That would certainly be appreciated. I will therefore move to a single vote on the 3 motions as we have agreed. Can I put the single question that the motions S5M 23216, S5M 23285 and S5M 23297 be approved? Are we all agreed? We are agreed. Therefore, we will report accordingly to Parliament, and we will no doubt hear further from the Cabinet Secretary in the way that he indicated very soon. Thank you very much for your attendance, Cabinet Secretary, and your officials, and we are agreed to those motions. I now move on to the next item on our agenda, which is agenda item number 6, which relates to EU exit statutory instruments, consideration of a consent notification proposing that the Scottish Government give consent to the UK Government legislating using the powers in the EU Withdrawal Act 2018 in relation to a UK statutory instrument, that is the Food Amendment EU Exit Regulations 2020. And I see, I'd invite comments from members. I see Sandra White, first of all.
Thank you very much, Convener. I have raised this particular issue in most of the European Union withdrawal acts. I am concerned, obviously it's to do with the Northern Ireland Protocol, but this particular one, I am concerned in regards to page 4, when it mentions country of origin information. Now, we know it's to do with the Northern Ireland Protocol, which basically mentions the fact that Northern Ireland produce coming into the Great Britain, as they don't call it the UK in this particular protocol, will be labelled differently. But at the very last paragraph on page 4 about country of origin information, basically it mentions about this SI would update Article 1, paragraph 2 to reflect new EU legislation covering names of spirit drinks, the use of the names of spirit drinks and other foods, use of geographic indications in the sector, and it adds a new Article 1A to define the United Kingdom. This is the one I'm quite concerned about. The United Kingdom as a whole to be a country rather than the constituent countries, Scotland, England and Wales. But they could be used separately in labels under place of provenance, but it doesn't necessarily mention that here, and it amends Article 2A to define region or geographic area to cover more than one country, and this is to move away from the term of member states and third countries. Yep. I just wanted a bit of clarification on that particular one. I mean, I know that on page 5, you know, basically they mention the fact that the Scottish Government will keep in contact with the UK Government to continue to look at this, and they are still concerned about the Northern Ireland Protocol and the continuity of law. So I just wondered, I know we wrote last week in regards to 2 weeks ago, we got a very good reply back, and I know that we don't want to hold things up, but I'm concerned about this particular one, particularly with the labelling, if it's just in the one country rather than, you know, the countries of origin, such as Wales, England and Scotland.
Absolutely fair point. And the recommendation from the Office of the Solicitor is that we should, if we give consent today, that we should ask about that specific point and ask for more information about that specific point, which I think would certainly make sense. Emma Harper.
Thank you, Convener. It's kind of similar to Sandra White's issue, but the Rural Committee have done work on statutory instruments as well, and one of the examples which relates to country of origin and labelling and traceability of food and food safety standards is one example from the Rural Committee, as I'm saying, was about veterinary medicine residues, which are residues that can be chemical residues that can be contained within the skin or the carcass of animals or meat as it's transferred from one country to another. And there are certain levels of residues that are acceptable, for instance. So I'm concerned that food standards might be compromised with future trade deals. And I've been following this with issues related to hormones used in beef cattle, but also in pigs. So issues of ractopamine and Carbamax, which is a particular antibiotic. So I note that the Northern Ireland Protocol is something that the Scottish Government needs to continue to engage with the UK Government about, and I'm especially concerned about how we track and trace our food produce when it's coming from external countries. So I'd like to just note that that's something that we will continue to be alert about, and I understand that the Rural Committee, which I'm a member of, is doing that also.
Thank you, Emma, for that point. Again, an important point. I think if the Rural Committee is following up that point, it clearly falls into their domain more directly than ours, though clearly we have an interest So it'd be very helpful if the Rural Committee can keep the Health Committee so informed, and perhaps ask you as a member of both committees to convey that we would be pleased to be kept informed of any reply that the Rural Committee receives. The recommendation in the paper is that we should agree to give consent, but also that there are a number of points in the draft letter from the Office of the Solicitor, which I think are important, and the advice from SPICE as well. Sandra White, I think you wanted to come back in on this before we move to conclusions. Yeah. Sandra.
Sorry, thank you, Convener. Maybe I've jumped the gun a wee bit, as you might say. When you mentioned to Emma Harper that the Rural Committee would be looking at this and keep the Health Committee informed, just for a point of clarity, does that mean that the Health Committee will not be writing to the Government with the concerns that were raised, or with the Solicitor's letter?
No, it doesn't mean that. My apologies if that was a confusing point to make. Veterinary medicines are clearly a matter that come under the remit of the Rural Economy Committee more directly than the Health Committee. But the issues, as I was about to note, and that you raised yourself, Sandra, a couple of issues. First of all, on the consequences of adding that Article 1A, defining the United Kingdom as a whole to be a country. That's important to understand what that means for provenance of Scotland and provenance of other parts of Great Britain, and whether that would see any material change. I think we would also, as we have done previously, ask to be kept up to date on the Scottish Government's engagement with the UK Government on the Northern Ireland Protocol. And thirdly, given that we have, unusually, but in a way that we would welcome, we have seen this SI. We are seeing this SI today in draft. That is an improvement, I think, on past practice, and something we would want to encourage and welcome in the letter as well. If members are agreed, then I would propose that we give that consent subject to those points being raised in the letter, in the relevant letter to ministers. Are we all agreed to follow that approach? That is agreed. Thank you very much. And we will now move into private session. I'll suspend the meeting for a moment and we will resume on another platform at 12 o'clock. Thank you very much.